This is Deborah Beck from Cardiosource World News. I'm here at the ACC 2012 with Dr. Robert Roberts. Dr. Roberts is the president and CEO of the University of Ottawa Heart Institute, and he's going to talk here today about personalized medicine. Dr. Roberts, you gave a talk here today. Can you give us a short summary of what you spoke about?
Well, personalized medicine, by definition, of course, refers to giving the right drug at the right time in the right dose to the right person. And that also means you would have ultimately base it on the genetic makeup of that individual if you knew their genes. For example, someone who is allergic to a bee sting, if you knew their genes, it's strictly because of their genes that they're allergic, you could avoid it or, in fact, treat it appropriately. Now, for heart disease, for heart attacks, coronary artery disease, the barrier for personalized medicine was that we didn't have the genes. The technology came in 2005, making it possible to run across the genome with hundreds of thousands of markers in thousands of cases and controls of heart disease. So in 2007, we identified the first gene, which is called 9p21, simultaneously identified the decode group in Iceland. It was published in Science, and then it began. Many people got into the act. We realized we needed huge populations in order to identify these genes. So we got together with 12 other centers in Europe and in North America, and we put together over 86,000 cases and controls, and we did billions of genotyping and identified, the first paper published last year, we identified 23 genes for heart disease. And along with other investigators over the next few months, the total now is 36 genes for heart disease. And what does that mean? First of all, we discovered something totally surprising to all of us. Of those 36 genes, 23 of them induce their risk for heart disease independent of all of our known risk factors, independent of cholesterol, blood pressure, obesity, diabetes, you name it. That means then that 23 genes are indeed acting through unknown mechanisms to cause heart disease. Clearly, we knew before we did the studies that about 50% of your susceptibility for heart disease is due to your genes. We all knew that we think this is the last century for heart disease because we can show 30 to 40% are prevented by treating environmental factors, which has been shown in large clinical trials. However, we didn't have the genes for the remaining 50%. So now we have them. Comprehensive prevention for heart disease will have to include both environmental and genetic. Now, in the process of identifying what is the mechanism for 9p21, we recently discovered that in the blood of people with 9p21 risk, and if they have heart disease, they have elevated levels of interferon alpha 21. What does that have to do with heart disease? Certainly we're not clear at the moment, but what we do know, 9p21 gene didn't come into the genome until higher primates, and neither did interferon alpha 21. They came together to protect as part of the immune system, and that's why humans have a longer half-life. And in the process, one of the complications presumably is you do form atherosclerosis and disease in your coronaries to give you heart disease. Now, what we have shown with this new test, and it's new, it has to be confirmed, obviously, with other investigators, is that interferon alpha 21 is significantly elevated, not only when you have 9p21, but only when you have the combination of coronary artery disease and 9p21 risk. So we have shown by coronary angiography very minimal disease is enough to elevate this test. So we believe that we have a new, truly biomarker, if you want to call it that. Now, what are the advantages of measuring genetics as opposed to cholesterol, blood pressure? Well, the average gene has about 20,000 units or bases. You only evolve, the rate of mutation is one base every 250 years. So your genes do not change in your lifetime, don't change in your parents, not very much in your offspring. So the result is you just need to get one blood sample in a lifetime. You don't need to repeat it again. The other advantage is it is not interfering with what you eat what drugs you take, et cetera, et cetera, et cetera. So the end result is it's a very stable thing, and that's why you only need to measure it once. Now, clearly its role in clinical management, it ultimately means you have to have something to modify management. It isn't enough just to test for it. And so how big a risk factor, for example, is 9p21? It's about the same as a chronic smoker. It's about the same as an increase of 15 or 20% in your lipid cholesterol. So it's a significant one. If you have 2 copies, one from your father, one from your mother, if you're unfortunate to get both of those, it'll increase your risk by about 50%. If you have 1 copy, about 25%. Clearly, what we must now find out is what will, in fact, prevent that risk, which can be done just because it's a gene. It's not that we can't find something, but give us time. It's only been 5 years.
So you still need to find a target for treatment.
Absolutely. We do not know what the target is. We think now, of course, it might be tied up with interferon alpha 21, but we don't have proof for that. But what we do know is that the two go together. For all of the others, as I've said, 23 are acting by unknown mechanisms. So we have a lot to work on. We suspect that a group of them will act to a common pathway, such as inflammation, and therefore you can use, there are drugs available today that are anti-inflammatory that would work along with lowering your cholesterol, your blood pressure, what have you. So it is a new era. I think that, but personalized medicine ultimately will be based on your genes. It's of interest to realize that since 2005, what you've seen happening with coronary artery disease has happened in 163 other diseases. The total number of genes available now is over 1,200 on those 160 diseases. So it's the beginning of a major onslaught, I think, for personalized medicine.
So at this point, we can't really treat that genetic risk, but we do understand how to tailor medications according to genetic risk. How is that linked in with what you've been talking about here?
The branch of drugs is called pharmacogenetics, right? That's dealing with your response to a drug. And obviously there are many drugs, we all respond to them somewhat differently. And so clopidogrel and aspirin are examples of that. About 30% of people are resistant to aspirin. So obviously, if you can test for the genes that make you resistant, you use an alternative therapy. And that's happening in clopidogrel. It is a large trial ongoing now in warfarin, for example. On the other hand, if you look at prevention of heart disease, I have to tailor the treatment to your genes. Let's take, for example, 9p21. If you're positive for it and you have a normal cholesterol, but you've got 9p21 risk, it would indicate one approach is that we should lower your cholesterol lower. Lots of people with heart disease have normal cholesterol. That's due to their genetic component. And so is it beneficial to decrease your cholesterol, even if it's in the normal range, and you have the risk factor of 9p21? Certainly the answer to that remains to be determined, but that would be the approach that we're thinking of. For example, right now, if you go and see a physician and your cholesterol is 160, not likely in your case because you're a female, but if it were 160 and you have no other risk factors, we say that's fine. If you got another risk factor, such as blood pressure, we would bring it to 140. If you have 2, we'd bring it down to 100. So one way to look at this, now that we know 9p21 is an independent risk factor, and if your cholesterol is 160, certainly we can see in the future that one may very well say, is this realistic? I think people will want more evidence for it, but one approach is, will that help you to lower your cholesterol even though we wouldn't have known before you had a risk factor?
Is, let's say, a positive test for 9p21, is that similar to, say, having a family history of heart disease or a family history of early onset heart disease?
Yes, most people who have a family history of heart disease, particularly for early onset, they are the ones who will have several of those genetic risk factors. It may not be 9p21, but 9p21 is very common. It occurs in 75% of all Caucasians.
Oh, really?
Yes.
Okay. And are we routinely testing for these genetic risk factors for heart disease?
Oh, I think that routine testing it's available in the United States right now. It's available, but it's not part of the routine, and it's certainly not recommended what to do because we do not know what we could do. I think ultimately 9p21 and all the other risk factors will find their way into the system when we can use them to change management. And at the moment, we have no solid evidence how to do that.
So we're not testing in order to advise people of their increased risk. We're kind of assuming that they are at increased risk or they aren't at increased risk, because you said 75% of the population, the Caucasian population, does test positive for 9p21.
Yes, 75% is positive for 9p21. But just because they have the risk factor doesn't tell you anything about do they have the disease yet, will they get it, and to what extent. That's the beauty of interferon alpha-21. If interferon alpha-21 is positive along with 9p21, that means you already have some disease and it's time to treat it. Now, the question is, we don't have specific treatment for 9p21, but we do have conventional treatment for conventional risk factors, and it would suggest you should intensify that particular form of prevention.
Very interesting. We've been talking to Dr. Robert Roberts about personalized medicine and relating to the talk that he gave here at the ACC 2012.